Hello again, friends. Our talk here is going to be on adenomyosis. I talked in a previous section about endometriosis. These two can get confused occasionally. However, clinically, they're very distinguishable apart from one another. The one thing you do need to keep in mind with adenomyosis, the major differential is going to be fibroids, leiomyoma. And so we'll discuss that and how we can differentiate them. Not terribly difficult, but some cases can be a little complicated. So we'll start with the vignette. A 42-year-old woman presents to your clinic complaining of heavy menstrual flow over the past 9 months. Normally she goes through about 2 pads per day, but lately has needed about 4 per day. She has also woke up with bleeding on her pajamas. Her menstrual period are predictable 28-day cycles. She is a G6P3033 with a history of 3 DNCs for spontaneous abortions lost between 12 and 14 weeks. All of her 3 deliveries were via C-section. She does have some mild pelvic pain, but most of the time it's relieved with Midol. She is monogamous with her husband of 20 years and has no history of STD. She is otherwise in good health and is on no medications. She does not smoke and she drinks alcohol only socially. There are no other complaints at this time. Physical exam is significant for a tender, boggy uterus. There are no masses. Okay, so we start out looking at this patient. Heavy menstrual flow, not an uncommon thing for a woman to present with, especially as they get closer to menopause. Not necessarily heavy menstrual flow so much as irregular menstruation. They'll not have their periods as frequently. But heavy menstrual flow is always concerning in any woman because of the possibility of developing anemia. So we always want to look into this. Now, the number of pads a woman uses is going to vary from woman to woman, and it also is going to vary on the type of pads she uses because some are more absorbent than others. But what you want to look at, not so much how many pads she's using. Obviously, if she's going through 10, 12 pads a day, that's not normal. But it's not so much the number of pads she's using so much as has it changed. Some women will go through 2, 3 pads a day. She's always gone through that many. She uses the same brand. That's going to be constant and normal. Now, other women who have a heavy flow or have developed a heavy flow will find that they have been using the same number of pads for 10 years and now suddenly they're needing more. That would be suggestive of a process going on that's causing them to bleed more. So it can be difficult with distinguishing how many pads is normal, how many is abnormal. Some women bleed more than others, so it's not necessarily very helpful. But look for changes when you're looking at heavy flow. Okay, so her menstrual periods are normal, so this is just menorrhagia, not metromenorrhagia, just menorrhagia. She does have a history of miscarriages, not necessarily associated with this, but we're going to get into when we discuss adenomyosis. There's some association with miscarriages. She also has a history of surgery to the uterus. We do consider DNC to be a surgery because we are manipulating the uterus internally. She has had 3 deliveries, all via C-section, so again, more uterine surgery. And then she's also got this pelvic pain, but that's mild. That's really not the reason she's coming in. She's coming in because of heavier menstrual flow. So we have a woman, heavy menstrual flow, a little bit of pain. One of the things that we need to always consider in a woman, especially a woman in her 30s or 40s who's presenting with heavy menstrual flow, is going to be adenomyosis. Now, there's other things that it could be. But this is one of the things that's going to be in our differential. Now, when we do the physical exam, there's other things that are going to point to adenomyosis. And that's going to be an enlarged uterus. And typically the uterus is going to be tender. If you were to further probe her and ask her about sex, she may tell you that occasionally she has some pain during sex. That's also consistent with adenomyosis. Now, you might be looking at this and thinking, well, how is this similar to endometriosis? And we'll talk about some of the similarities in a little bit. All right, so there are no masses. That's important because one of the things that we want to distinguish this from is leiomyoma, fibroids. Fibroids will bleed. They do bleed. However, fibroids typically aren't painful so much. And this could easily be fibroids because there's not as much pain going on. It's just mostly bleeding. One of the tests we're going to do is a sonography, transvaginal sonography, and that will really help us distinguish this from fibroids. Okay, so we'll talk about the pathophysiology, which has not been fully elucidated, epidemiology and risk factors, presentation, workup, and management. So adenomyosis is characterized by uterine enlargement caused by ectopic rests of endometrial tissue within the myometrium. So this is different from endometriosis. There are some similarities. Endometriosis, you have endometrial tissue where it should not be, and with adenomyosis, you have endometrial tissue where it should not be. It shouldn't be in the myometrium. It should be outside the myometrium, along the lining of the uterine cavity. So we do have endometrial tissue where it shouldn't be, but with endometriosis, that endometrial tissue will be outside the uterus. It can be on the uterosacral ligament. It can be elsewhere. With adenomyosis, it's solely in the myometrium. It can be diffuse or focal, so you can have little bits and pieces, foci of endometrial tissue all over the myometrium. That would be considered diffuse adenomyosis, or it might just be in one spot. And so you just have an enlargement in one part of the uterus, and you can imagine that's the one that's very difficult to distinguish from fibroids because you just have a little area or maybe a few little areas of uterine enlargement, and that can feel like a fibroid when you do your physical exam, or fibroids. But most of the time it's going to be diffuse enlargement. So adenomyosis differs from endometriosis, but there are some features that it shares in common. So they're both, as mentioned, characterized by ectopic endometrial tissue. They also both cause pelvic pain, pretty similar pelvic pain. There are some differences, though. We'll talk about it in a little bit as far as the characteristics of the pain. Both are also hormonally sensitive. So increased estrogen is going to cause enlargement, proliferation of the endometrial tissue, and so that's going to worsen the symptoms. So a lot of times the pain will come around the time of menstruation. So both endometriosis and adenomyosis will experience dysmenorrhea, pain during menstruation, specifically secondary dysmenorrhea. As mentioned, both cause pain, and they're both also related to prostaglandin levels. So remember, in the endometriosis lecture, if you watched that, you would have seen that endometrial implants, that endometrial tissue actually has more expression of COX-2, and so there's more prostaglandins released by that tissue, and that's going to cause pain or contribute to the pain. Adenomyosis, we call them adenomyotic foci. Those are also, that tissue is also going to have elevated prostaglandin levels, very similarly to the endometriosis. And then both will significantly remit after menopause because they're hormonally sensitive. So there are some similarities. Now we're going to focus on the differences. But first we're going to talk about the pathophysiology in greater detail. If you're taking step 2 or step 3, don't worry about pathology. Don't worry about looking at things under microscopes. Not important. But I want you to look at this to get an idea of what's going on. So here we have the endometrium, and here we have the myometrium, and then the perimetrium, which is the external serosal layer of the uterus. All right, so what we have, here's the endometrium. This is a normal uterus, by the way. This endometrium, you can see that there's these sort of crypts, and these will proliferate during with the periods when the woman hits her fertile period. And then you have the myometrium here, and the myometrium is just a smooth muscle layer. Now, there's something very unique about the uterus, and that is that in between the endometrium and the myometrium, there's really nothing. It just goes from endometrium to myometrium. And normally at mucosal muscular interfaces, so endometrium is mucosal, myometrium is muscular, normally at these mucosal muscular interfaces, there's typically a submucosa that intervenes in between the endometrium and the myometrium. Not so in the uterus. So the uterus is unique in that regard. Now notice, though, that the tissue of the endometrium is very different appearing than the tissue from the myometrium, and perimetrium is a little bit different from the myometrium. It's kind of hard to tell at this power, but these are very distinct layers. Okay, so this is a better look at the tissue here. So note that you have endometrium here with those crypts and the secretory tissue. You have the smooth muscle of your myometrium, and then down here you have the perimetrium. Now, the stratum basalis is the most external, superficial, if you're talking about the uterus as a whole, most superficial layer of the endometrium. And this is going to be the layer that's implicated in adenomyosis. So let's look at, Okay, here we go. I'll just take a look at this now. So this is the myometrium here. These fibers, there's kind of like a cross-section here of the fibers, the smooth muscle fibers. And note here, this is totally abnormal. You have the secretory tissue here. This is where we get the name adenomyosis. Adeno meaning glandular. So you have the glandular tissue in your muscular layer, and that's not normal. So this is glandular tissue, and this is endometrium in the myometrium. Okay, so that's what these are here. See, it looks just like it. This is the tissue pattern that you see down in the myometrium. And what is thought to happen is that the stratum basalis invaginates and causes tissue from the endometrium to migrate into the myometrium. Now, note though that the basalis tissue it does not undergo proliferative changes with the menstrual period. It's kind of hard to tell here because you just have one cross section, but as the menstrual cycle progresses, you don't have any kind of proliferation of the stratum basalis, and the result of that, why that matters to us, is that you're not going to have internal hemorrhaging in the myometrium. So you're not going to have blood collecting in the myometrium because you don't have any extra vascularization in the myometrium that's going to cause blood flow once the menstruation happens. But what does happen is when you have this tissue, this endometrial tissue in the myometrium, there's going to be excess blood vessels in the endometrium that's going to feed that adenomyotic foci. And so the result of that is that you do have excess blood vessels surrounding the adenomyotic foci, but they're not in the myometrium. They're going to be in the endometrium. And so that's why you have that excess blood flow during when you have adenomyosis. But you're not going to have hemorrhaging in the myometrium itself. Okay, so the pathogenesis, not fully known. As mentioned, it most likely is due to a direct invasion of the endometrium into the myometrial layer, which results in those foci of endometrium within the myometrium. So both the increased vascularization of the endometrium near the adenomyotic foci, as well as ectopic estrogen production, very similar to the pathophysiology we see with the excess estrogen production in endometriosis, that's going to stimulate that tissue. And so both of these are going to cause increased bleeding. They're going to contribute to increased bleeding. And then also remember, the reason we get the pain is probably due to increased prostaglandin production in this foci, very similar to endometriosis. Risk factors. So most women who present with adenomyosis are going to be in their 40s and 50s. That's very different from endometriosis. A lot of women who present with endometriosis, they could be teenagers, they could be in their 20s. Most women with endometriosis will present as young women. With adenomyosis, they tend to present as older but not menopausal women. So they're usually in their 40s, even 50s, but they're not menopausal because once they hit menopause, this should get better. There's also an association with multiparity. So 90% of cases of adenomyosis happens in women who have had children. Now, the reason for this is probably due to the trauma to the uterus that normally occurs during delivery. You get trauma and that stretching occurs. You have trauma to that endometrial-myometrial boundary. And so it's easier for endometrial foci to invade the myometrium. We also see an increased incidence of adenomyosis in women who have had prior uterine surgery, probably the same reason. You get that trauma. Other possible risk factors include things like smoking, not sure why, antidepressants, and tamoxifen. The antidepressants is probably because it alters the dynamics of prolactin, and that is going to that's going to affect the chemistry of the uterus. Tamoxifen is essentially estrogen for the uterus. So remember, tamoxifen is one of those selective estrogen receptor modulators where it sort of inhibits the action of estrogen in one area and then acts as an agonist in another area. So tamoxifen works as an antagonist in breast tissue, an estrogen antagonist in breast tissue, and it works as an agonist in the endometrium. So it works differently in different areas. Remember, we give tamoxifen for women with estrogen progesterone positive breast cancer. So you may see that in that context. So the fact that it is an estrogen agonist in the endometrium is thought to be why it contributes to adenomyosis, possibly. These are possible risk factors. These other ones, though, are known risk factors. Age, parity, and prior uterine surgery. Okay, so again, here is your adenomyotic foci within the myometrium. So you can see here, again, on the right side here, on the patient's right side, this would be a normal uterus. And then on the patient's left side, this is a demonstration of adenomyosis. Now, in most cases, adenomyosis is going to be more or less evenly distributed throughout the myometrium. But in some cases, you can have it just in one area. So if you were to look at this, you might describe this as focal adenomyosis. But what this is just showing you is how normal uterine tissue looks and adenomyotic uterine tissue looks like. And this is just obviously an illustration, but these are your adenomyotic foci here, which correspond to these foci here. The epidemiology, we don't really know how many cases happen because so many of these it's underdiagnosed, and a lot of these are diagnosed after hysterectomy. The frequency at hysterectomy, for any reason, it has been reported between 20 and 60%. A huge variation depending on studies. A lot of these women, though, will not have symptoms. There's no data on racial differences. That's unlike endometriosis, where we believe it happens more in Asians and whites than in blacks and Hispanics. And then, unlike endometriosis, adenomyosis, as we talked about, tends to present in older women, but still premenopausal. So women in their 30s and 40s as opposed to teenagers and 20s. Only about 1/3 of women with histologic adenomyosis will have symptoms. And a lot of times those symptoms are so mild that it doesn't get actually diagnosed. So it might just be a woman with heavy flow, but she doesn't really think twice about it, never gets diagnosed with it. So adenomyosis is very common, very underdiagnosed, and a lot of the women who have it, they don't have symptoms, or their symptoms aren't bad enough to where they seek any kind of treatment. So it's usually the severe cases that are the ones that seek treatment. Many women with adenomyosis will also have fibroids, and a lot of them are also at mildly increased risk for endometrial carcinoma. Why is that? Because these women likely they just genetically have higher estrogen levels. They have higher expression of aromatase, and so they have higher estrogen levels. And estrogen contributes to all of these: leiomyoma, adenomyosis, and endometrial cancer. So they may be at increased risk for endometrial cancer. Not 100% certain on that. We're still studying that. But we do know that there is a very high correlation between adenomyosis and uterine fibroids. The presentation. The most common presenting symptom of adenomyosis is abnormal uterine bleeding, namely menorrhagia, as well as secondary dysmenorrhea. So it should be on your differential in any woman who has increased menstrual flow and any woman who is presenting with secondary dysmenorrhea. The severity of symptoms will correlate with the number of foci and the extent of invasion. And that makes sense because sort of the pathophysiology here is that you have these foci and then the endometrium becomes more vascularized over those foci, over the myometrium that has those foci. And so the more vasculature you have, the more you're going to bleed when you have your period. This is unlike endometriosis. With endometriosis, the severity of symptoms do not at all correlate with the number of endometriotic implants. They do correlate with endometriosis. Does correlate with the depth of invasion, but it does not correlate with the extent of the disease itself, with the number of implants. With adenomyosis, it does correlate with the number of foci. 10% of women with adenomyosis will complain of dyspareunia. So that's pain during intercourse. And the reason it's probably not as much as endometriosis is probably because with endometriosis, the dyspareunia a lot of times is caused from the endometriosis tissue being on the uterosacral ligament. You do not get that in adenomyosis, remember, it's limited to the myometrium. But you still have pain, you have all those prostaglandins, and so you do still have pain with adenomyosis when the uterus is moved around and manipulated. You can get some pain, and that can happen with adenomyosis, and you can get dyspareunia that way. Fertility issues are typically not a problem with adenomyosis, but they do have an increased risk. The reason it's not so much a problem is because women typically don't develop problems from adenomyosis until they're older, and typically they're not trying to get pregnant at that point. So they don't complain of problems with fertility. However, we do know that with adenomyosis, there's an increased risk for ectopic pregnancy. So what can happen is that the fertilized embryo, the fertilized egg, the embryo, will get in a little bit deeper into the endometrium, and if it finds endometrium in the myometrial layer, it can implant there, and that would be an ectopic pregnancy. Okay, so we saw this patient, and she had a few miscarriages, but that's not necessarily due to the adenomyosis. The reason I put those miscarriages in there was because it caused her to get the DNCs, which then did increase her risk for adenomyosis. But certainly if she had a history of ectopic pregnancy, that would certainly be consistent with adenomyosis as well. But most of the time, women who have ectopic pregnancies, they don't have adenomyosis. Okay, physical exam. Visual inspection, speculum examination is going to be normal. This is in the myometrium of the uterus, so there's not going to be anything wrong with the vagina, the vulva, the cervix. It's all going to be uterus. When you do your bimanual examination, you will typically find an enlarged and tender uterus. Because most cases of adenomyosis are diffuse, it's going to be a confluently enlarged uterus. Now, in cases where you have focally located adenomyosis, it can be very similar to the fibroids because you just have it in certain areas, and those will feel like bumps. They'll be just focally enlarged portions of the uterus. Leiomyomas, fibroids, they will typically elicit a lumpy, bumpy texture, but that's very difficult to distinguish from focal adenomyosis. So that is where you can run into some problems on physical exam. But like I said, most cases of adenomyosis are diffuse, and so you'll get this enlarged, slightly tender uterus. Now this is a little bit different from endometriosis. With endometriosis, you will have a tender uterus, but it won't be necessarily enlarged. You may feel masses, or you may feel some bumpiness along the uterosacral ligament. So it's a little bit different. But with adenomyosis, it's going to be this confluent, enlarged, tender uterus in most cases. What do we do for workup? Well, because a woman comes in complaining of pelvic pain, we need to do a pretty complex workup here, just looking for all the common things that pelvic pain could be. So we're going to get a CBC looking for infection. It's also good in adenomyosis and really any woman who complains of menorrhagia to get a CBC looking for anemia. So we would look for decreased hemoglobin, hematocrit, and then also a decreased MCV. We want to get a urine pregnancy test. Just any woman with pelvic pain remember, urine pregnancy tests, super cheap to do. And if a woman has pelvic pain, you're always considering at least the possibility of pregnancy. So get that out of the way. Get a urinalysis and culture. Pelvic pain can easily be UTI. A lot of women get UTIs. And then vaginal and cervical cultures. You don't necessarily need to get that, especially if a woman, if you trust that the woman has not been having promiscuous sex, but it's a possibility. I would err on the side of caution. Again, it's a cheap test. So vaginal and cervical cultures. Imaging. The best initial test is transvaginal sonography. But the problem with transvaginal sonography is not very good at distinguishing adenomyosis from fibroids. The other problem is that in general, it's very difficult to diagnose adenomyosis on transvaginal sonography. MRI makes it much easier to diagnose adenomyosis. You can see things a lot better. So just based on the difficulty of diagnosing adenomyosis on transvaginal sonography, a lot of gynecologists will just go straight for an MRI. But transvaginal sonography should be your initial test. If you have a really good sonographer, then you'll probably be able to diagnose adenomyosis a lot easier than if you're not as experienced. And an MRI would get you your diagnosis better in that case. So it really just depends. General rule of thumb with sonography is that it really just depends on how good the sonographer is. So if you're unsure and you're doing the sonogram, you're unsure, send her off for an MRI. The findings on transvaginal sonography, don't worry about this for test-related purposes. Like I said, it can be very difficult to diagnose adenomyosis on transvaginal sonography, but I put this in there because it kind of correlates to the pathology. So increased myometrial thickness, that's due to the myometrial implants being in there, can cause, the adenomyotic implants being in there, that can cause the myometrial layer to appear globally thicker. Myometrial heterogeneity due to very small implants. So we noticed that those little foci of endometrial tissue in the myometrium, at least on this picture, they were quite small. Look how small these are. You're not going to pick that up on sonogram. You're not going to see distinct masses on sonogram. But if you have a bunch of those and they're really small, it's going to cause the myometrium to appear heterogeneous. Okay? If they're large enough, then you can see hypoechoic cysts in the myometrium. And then sometimes you can see these striated projections from the endometrium into the myometrium. They call that, I think it's called a Venetian blind appearance. Don't worry about it. Okay? Now, as far as, I want to go back here, because I want to describe some of these symptoms and how you can, other ways you can distinguish them from endometriosis, because they both can present with pelvic pain. I want you to get this down for clinical purposes at least. So a lot of women will describe the pelvic pain from adenomyosis to be very similar to uterine contractions, that sort of dull pain that they got during childbirth. And the reason for that is that the pain is coming from the myometrium, so it's going to be similar to contractions. On the other hand, with endometriosis, they'll typically describe it, they won't be able to localize it to the uterus or the pelvis so much. It'll be more generalized lower abdominal pelvic pain. And with endometriosis, occasionally it can radiate to the back, to the lower back. And the reason for that is if you have uterosacral endometriotic implants, that's going to refer to the back because it sits on the sacrum. Okay, so that's one way that you can distinguish it. But with adenomyosis, women will oftentimes be able to localize it to the uterus, or at least the pelvis. Okay, so this is how a normal uterus looks on gross visualization. So just notice that it's relatively small, about 6 centimeters in length. And this is where the cervix would be, and then up here's the dome of the uterus. This is adenomyosis. So this is focal adenomyosis, but I just want to put it like this to help you compare sort of the more normal region of the uterus to the adenomyotic uterus. You don't necessarily see any kind of hemorrhaging here, and the reason, like I said, is because the hemorrhage is coming from the endometrial layer, but you just have increased vascularization from the adenomyosis. You don't have vasculature, you don't have a lot of vasculature in the myometrium itself along those implants. So that's not going to be the source of your bleeding. The source of your bleeding is going to be the extra vascularization in the endometrium that's ultimately feeding those adenomyotic foci. Okay? Hopefully I made that clear. But nonetheless, you're going to have menorrhagia. So what do you do for management? We're worried about two things. We're worried about pain and controlling the bleeding. Okay? The way that we treat pain, generally the best way to treat menstrual pain is going to be NSAIDs. Dysmenorrhea, NSAIDs. Get those two together. You should make a word correlation between the two of those, word association. NSAIDs, menstrual pain, dysmenorrhea. Now, the thing with adenomyosis is because we also have bleeding, we will typically be treating the bleeding with oral contraceptives or progestins. Those also work really well for pain. Why do they work for pain? Because the progestins will, the progesterone component of the combined oral contraceptives or the progestin, those will shrink down those foci. So the result of that then is that you're not going to have active, the endometrial tissue will not be as active, and so consequentially you're not going to have as much the prostaglandin formation, because that is part and parcel of those cells being active. So really you're killing two birds with one stone here, and so oftentimes this will be the first line of therapy. So you're preventing the bleeding by preventing the menstrual cycles, you're also preventing the pain by causing this tissue to shrink, and the myometrial tissue will, the adenomyotic foci within the myometrium will shrink as well. So oral contraceptives or progestins are typically the first line of therapy. Notice combined oral contraceptives. You can't use estrogen alone. You shouldn't anyway, but you can't use estrogen alone. You need to have a progesterone component. So this is typically the first line that we go to, and then if that doesn't fully help with the pain, then you can give a woman NSAIDs to use for additional pain management to hit any kind of like breakthrough pain, I guess you can call it. So that can be prescribed in addition. But a lot of times she'll be able to take over-the-counter stuff like Midol for the pain. Now, in the event you have a woman who wants to become pregnant, then obviously you don't want to use oral contraceptives or progestin, so you'll just go for NSAIDs. And you can give her a slightly higher strength, prescription strength NSAID to help with the pain. Since you're not using the contraceptives, you may need something a little bit stronger in terms of NSAIDs. Remember, you might be thinking, oh, NSAIDs, pregnancy, bad. NSAIDs are okay early on in pregnancy. After 30 weeks is when we worry about NSAIDs because of its association both with oligohydramnios as well as with premature closure of ductus arteriosus in baby. So later on in pregnancy, we don't want to use NSAIDs. But if you're using NSAIDs in a woman who's planning on becoming pregnant and then she becomes pregnant and discontinue them, you're not worried at all about anything going wrong with the baby. Hysterectomy obviously is going to be the most definitive management. You remove the uterus, you cure the adenomyosis. Not so much the case with endometriosis. With endometriosis, you need to remove the ovaries as well because it's estrogen sensitive and because you have foci outside the uterus. With adenomyosis, once you remove the uterus, you've removed all the diseased tissue, and so you're good to go. You don't need to remove the ovaries. Other surgical techniques that are commonly used include endometrial ablation and uterine artery embolization. I've read some articles, though, saying that these are really a bad idea. So there's probably some controversy, but I would not opt to use these because there's controversy about it. Hysterectomy would be the best surgical way to go. Plus, think about it. Adenomyosis gets worse with surgery. Surgeries increase your risk of adenomyosis. So why would you want to do more surgery on a woman who already has adenomyosis? That could make it worse. So if you're going to do any surgery, do a hysterectomy. If the woman wants to preserve her fertility, or I should say her ability to bear children, then NSAIDs are the way to go, and oral contraceptives until she wants to become pregnant. All right? So any questions, go ahead and write me a note below. Otherwise, I will see you in the next lecture.